Thank you. I've seen Dr. Kasim. So I think we are all in. Good afternoon, everybody. I'll just start us off. My name is Dr. Phoebe Juma, and I want to welcome you for this presentation on Candida auris. We'll have several presentations. We'll start with an introduction from Dr. Lois Ombajo. I'll present on the clinical aspects, and then Dr. Kasim on the laboratory considerations, and we'll have prevention by the IPC specialist, Sylvester. So I'll hand over to Dr. Lois Acheng to give us the introduction. Welcome, Dr. Lois.
Thank you so much, Dr. Phoebe, and good afternoon, everyone. I hope you are well. I think today it's really our privilege to be able to present some work that we have been conducting over the last close to 4 years now. And this is work on Candida auris. And the work on Candida auris is really in the background of a lot more work that's being done around improving lab capacity for identifying Candida. I think when we started this work about 4 years ago, one of the things we knew is that there's probably a lot of Candida infections that would go unidentified. And there's also a lot of antifungal use empirically for what may not have been Candida infections. So we started one by building capacity of several labs in the country. Starting with KNH and expanding to several labs in the counties. At this point, we work in about 9 labs around the country. And the capacity building was in terms of training different facilities, training the labs, training clinical teams in order to be able to identify patients who are at risk of candidemia, training lab teams so that we're not just isolating bacteria, but being able to not just isolate, but identify and do antifungal susceptibility testing. So over the years, we've gone from just looking for colonization with Candida. We've been doing active surveillance for candidemia, so Candida in blood. And in the process of this work, we've identified the fungus known as Candida auris that the rest of the team will be talking about today. And why would we do a whole webinar on just this one fungus? So Candida auris is a pathogen that has been doing rounds in Kenyan hospitals. And the reason we are particularly concerned about it is that, one, it tends to be very resistant to several antifungal agents, and it's very difficult to eradicate once it establishes itself in a unit within the hospital. So today we'll get an opportunity to look at the clinical aspects of invasive Candida infection, the specific lab things around not just other Candida species, but even around identifying Candida auris, and also importantly, how to prevent and contain Candida auris when it does occur. So grateful for the opportunity to present, and I'll just keep it brief because there are a number of presentations, and invite my colleagues to go ahead with this. So Dr. Phoebe, back to you. Thank you.
Thank you, Dr. Lois, for that introduction. Let me share my screen. Please post, for the attendees, please post your questions on the chat and we'll take them at the end of the 3 presentations. Is my screen visible?
Yes.
Okay. Yeah. Let me go to the first one. Yes. So I will be presenting the first part, which will be on the clinical aspects, where we'll talk about a case of Candida auris that we managed at Kenyatta National Hospital. We'll just cover a few details on the case presentation, some definitions, look at risk factors, a bit about pathogenesis, clinical presentation, and treatment. So we'll start with a description of the case. We had KAP, a 30-year-old female, who was admitted to the facility on the 24th of September, and she was with us for a period of 2 months. She had come as a referral from Kajiado County Referral Hospital, and at presentation, the history was really scanty. So she had a reduced conscious level. The cause was not known, and she was diabetic. They had diabetes mellitus and was in diabetic ketoacidosis. And the reasons for referral were for critical care and for further investigation for the low GCS. So scanty history was available on what management had been done for the patient at her previous facility. But what we knew is that she had acute kidney injury and had been initiated on hemodialysis. So on examination, she was sick looking, she was comatose and had been sedated. She was hypotensive with a blood pressure of 99/49, tachycardic, saturating well, but also had a fever of 38. Her GCS was low at 5T/15, had pinpoint pupils, which were non-reactive, and had no neck stiffness. In her respiratory system, had decreased air entry bilaterally, but cardiovascular system was normal and her abdominal exam was normal. In her laboratory tests, what was notable was an elevated blood sugar. She was diabetic anyway. She had deranged renal function, hypernatremia, and a metabolic acidosis. So she was immediately admitted to the critical care unit where she was commenced on DKA protocols of insulin administration, supplementation of potassium, and because of the signs of sepsis, she was also started on broad spectrum antibiotics. So initially ceftriaxone, and when there was no response with persistent fevers and elevated inflammatory markers, a switch was made to piperacillin tazobactam a few days later to cover for hospital-acquired infections. So within a week, her DKA had resolved, but the patient was still spiking fevers. And on further evaluation, her dialysis catheter was noted to be oozing this serous fluid. To cover for possibility of coagulase negative staph infections, vancomycin was added to her regimen, and blood culture samples were taken at that point. 4 days later, we received a notification from the lab that Candida auris had been isolated, but they were awaiting antifungal susceptibility testing. So immediately, IPC measures were instituted, including barrier nursing. There was a plan for reciting of her central line, which was oozing some fluid. There was a change of her other invasives, including her urethral catheter, and environmental hygiene measures were instituted. She was commenced on caspofungin, and the plan was to maintain this for the next 14 days, at least the next 14 days. So we later received the AST report, and it supported our choice. The isolate was sensitive to the echinocandid, so micafungin and caspofungin. And it was also resistant to fluconazole and voriconazole. Blood culture done a few days later after instituting treatment was negative. There was no growth on both bacterial and fungal cultures. Due to her depressed conscious level, decision was made to add liposomal amphotericin B to her treatment because we were querying a possibility of a CNS fungal infection. The patient was not improving, she was not regaining consciousness, and there was this lesion that had been visualized on a CT scan that was done. However, much later, we were able to get CSF studies after a normal fundoscopy, and the CSF was clear. The gram stain, there were no organisms, there was no Cryptococcus neoformans seen, and the biochemistry was also within the normal ranges, and we were also able to rule out TB. The gene expert for TB was negative. So other imaging done included a chest CT scan, which showed a focal pneumonic process and a small localized reactive fluid collection. And a CT scan of her neck, which just showed a small insignificant node of 7 millimeters. So much later, we were finally able, sorry, let me just go back to that slide. We were able to get a brain MRI, which was able to give us a better explanation for the sustained low GCS in this patient. And she had an ill-defined lobulated suprasellar mass extending into the suprasellar cistern, compressing the third ventricle with ventricular dilatation. And the impression was made of a pituitary macroadenoma with hemorrhagic transformation. Query, a craniopharyngioma. She also had multifocal ischemic lesions in her cerebral hemispheres. This is a summary of her lab investigations, just to illustrate what we have just said. So at admission, this patient had deranged kidney function, but you can see over time, the renal function improved and resolved, and eventually we were able even to remove to stop dialysis for this patient. On this slide, we have her liver function test, but we also have her inflammatory markers, which are in the last two rows on the last three rows on your right. So you can see her inflammatory markers also came down pretty well with institution of our antifungal medications, which we started around this date when we got the results from the lab. On this slide, because she had a craniopharyngioma, we also screened her for other hormonal abnormalities, but the hormonal profile, especially the thyroid hormone profile, was within the normal ranges. So other investigations that we did included her HIV test, which was negative. We also looked at her HbA1c because she's a diabetic, which was 7.3%. We also screened for tumor markers. At some point, we cultured a Klebsiella pneumonia, which was resistant to meropenem, but nothing was done because at that point, the patient was stable and didn't have signs of sepsis. So we thought it just reflected colonization. So the patient did well. Due to prolonged intubation, a tracheostomy tube was inserted, but she recovered well enough to be taken off the ventilator. Her hemodialysis was discontinued, but she never fully regained her consciousness. She was eventually able to be transferred out of the isolation ward, but unfortunately succumbed about 2 months later. And we think the reason for her death was the CNS tumor. So in summary, I presented to you a young female who was admitted to a critical care unit with diabetic ketoacidosis and features of sepsis due to invasive Candida auris. Later found to have a craniopharyngioma with multifocal brain infarcts. So I'll just give a brief discussion around a few aspects on this case. So we'll start by understanding what invasive candidiasis is. So basically what it means is isolation of Candida in sites which are normally sterile. So in our patient, we had a blood culture which was positive for Candida auris. So most of the times, Candida species cause superficial infections, and this just cause morbidity, which means pain and maybe limitation of feeding and discomfort to the patient. But invasive Candida infections are really important because mortality is quite high if they're not treated. So the mortality is about 30 to 40%, which is like 1 in 3 patients with candidemia, with invasive Candida infection, will die. Systemic candidiasis contributes to more mortality than any other type of systemic fungal infection. So invasive Candida is an important healthcare associated infection, especially in the critical care setting. It also has economic impact because you have a considerably prolonged hospital stay. Like for our patient, we are going to start our minimum duration of treatment is 14 days from a negative culture. We also have costly medications, and in other economies in the US, they've estimated the cost to the economy from these infections. So there are 15 species of Candida that cause infection in humans, but invasive candidiasis is mainly due to the 5 species listed here. So Candida albicans, glabrata, parapsilosis, cruceae, tropicalis, with Candida albicans being the most common. But with time, more resistant fungi, as we use more antifungals, more resistance has emerged, and now we have Candida auris showing up and playing more of a role with increasing numbers of infection. So Candida auris is of particular concern. Was first described many years back in 2009, where it was isolated from the ear of a patient in Japan. But since then, it has spread globally, and now more than 30 countries have described cases. So why is it so important? It's a multi-drug resistant yeast, and over 50% of the isolates are resistant to all antifungals. So it causes invasive infections, it contaminates the healthcare environment, and unlike the other fungal infections, it can be spread between patients. It has caused outbreaks and tends to persist to be resistant to routine disinfectants. There's also a bit of difficulty with identification in the lab, which will be covered in subsequent presentation. And then the mortality is even higher than the other Candida species. So the World Health Organization has recognized this, and it's actually listed as a priority pathogen for research and development of medications and just for public health action. So even locally, it's not just an international problem. Locally, we've had outbreaks, and there's one that was described, and even a paper was written by Dr. Lois, where 32 patients with Candida auris were described. There was an outbreak described between 2017 and 2019 at a private facility. And the mortality for this cohort of patients was quite high. It was at 64%. And the commonest presentations were with sepsis, pneumonia, post-surgical care, and about 97% of them had a central line in situ. Which brings us to the next slide. What are the risk factors for invasive candidiasis? Is it possible to pick out these patients? So the risk factors are summarized here, and basically it's devices, indwelling devices, things that will push Candida from the skin and into the bloodstream, things that will suppress immunity, and so including things that will increase colonization by resistant fungal pathogens. So this includes things like antibiotic use, indwelling intravascular devices, parenteral nutrition, things like glucocorticoids, cytotoxics, immunosuppressive therapy, patients with severe burns, neonates. So anyone with depressed immunity, invasive procedures being done, central lines being inserted, those are the patients who are at risk of invasive candidiasis. So our modern medical practices have led to an increase in Candida infections. So the widespread use of antibiotic agents, antifungal agents, chemotherapy, the immunosuppressive therapies, insertion of indwelling devices, and conducting abdominal surgeries. So are there prediction scores that we can use to help us with deciding who to give antifungals even prior to getting the sensitivity culture reports? Unfortunately, the prediction scores have not fared well. There was this one called the Candida score, which was based on parenteral nutrition, previous surgery, multifocal colonization, and severe sepsis, where a score of 3 was considered, then Candida was considered highly likely. But the prediction models they have relatively good sensitivity, they have a poor positive predictive value. There are a lot of patients who do not have candidiasis who would score who would get that score of 3. So instead, what they have is a high negative predictive value, meaning they are more useful in identifying those who would not benefit from antifungal therapy. So more research is needed before this prediction scores can come into use into the guidelines. So what is the important things in the pathogenesis of invasive candidiasis and how it causes disease? Candida species generally are commensals, so they are found on the skin, they are commensals in the GIT tract. So colonization precedes infection, and most infections, invasive candidiasis, is actually from the Candida that is colonizing us. So the entry points are via the gut, from where the Candida is colonizing, an IV catheter when it's pushed in from the skin to the blood, and from other localized foci of infection. Important among the virulence factors is biofilm formation, meaning that for patients who have like long lines in, the Candida tends to form biofilm on those devices and on those long lines. So this diagram just illustrates that. So the Candida moves from the site where it was colonizing and moves into the circulation. And then from the circulation, it's capable of causing what we call metastatic infections. So it will cause a bloodstream infection, but then it can spread to almost any site in the body because it's in the bloodstream. So the clinical features of candidiasis, there is what we are familiar with, which is the mucocutaneous candidiasis, which can have these varied presentations listed there from oral thrush, vaginitis, depending on the site at which the candida is located. And then now we have what we said is invasive candida infection, where the candida has gone into blood and has spread to other organs. So what is important to note here is that there are no unique features. So when the candida is in the bloodstream, the most common presentation will be sepsis, which is not unique to candida. So once it's in blood, you can get hematogenous spread to other sites, and then now you'll have symptoms related to where the metastatic infection has gone. So if it goes to the brain, meningitis. If it goes to the joints, you'll get an arthritis. So what is important is that candida isolated in blood should never be considered a contaminant. And you should consider, because it's in the bloodstream, it can spread anywhere. You should consider metastatic infections in patients who have persistent positive cultures in spite adequate treatment or persistent fevers. Also important is that candiduria is common. That means isolation of candida in urine and doesn't always indicate infection. So you don't have to treat every time there's a positive culture. So this was just an illustration. Patients with candidemia can also have skin lesions. And this is a patient with candidemia with lesions in the kidneys. So we have said the most common presentation of candida is sepsis. So clinicians have to be really good at recognizing sepsis. So we have this Surviving Sepsis campaign, which is a guideline and guides us on how the clinical diagnosis of sepsis. They set the criteria. So sepsis is basically a life-threatening organ dysfunction caused by the host's response to infection. And the important thing here is that sepsis is a clinical diagnosis. So there are various criteria that you can use scoring systems that you can use to diagnose sepsis, but maybe the one that has persisted over time is the SARS criteria, which I'll describe here. So at least two of the following features. So a temperature above 38, heart rate more than 90, a rest rate more than 20, or a white cell count of more than 12. And I'm sure you remember our patient's history. Our patient had those features. So a focus of infection and any two of those, and you can say the patient has features of sepsis. So this is just highlighting the same. Previously, we had 3 categories of sepsis, but now they have been simplified into 2. So you just have sepsis and septic shock. So how do we treat the patients? So antifungal, this is just a slide summarizing the antifungal drugs that are available, but actually only 2 classes of antifungals are used in the treatment of Candida auris. So our first-line agents are the echinocandins, of which there are 3 that are available locally, anidulafungin, caspofungin, micafungin. And monotherapy is adequate, especially once you have the sensitivity. There's a survival advantage for using the echinocandins to treat candidemia, and they have, generally, as agents, they have minimal adverse effects. However, they are embryotoxic, so they should be avoided in pregnancy. They achieve good concentrations in all sites except for the eye, the CNS, and the urine. So for those sites, you have to consider using other agents or using combination therapy. No dose adjustment for renal therapy, and they're also not metabolites of cytochrome P450, meaning they don't have many drug-drug interactions. However, they are costly and their availability is limited. I'm not sure how many facilities within our country have access to those antifungals. Amphotericin B is familiar to all of us, especially due to HIV-related illnesses managed with it. So it's the second-line treatment indicated for treatment failures, intolerance, or unavailability, maybe of the echinocandins. So it's also important where the echinocandins cannot be used. For example, CNS infections, eye infections, or pregnancy. When it comes to azoles, there are high levels of resistance to fluconazole. However, azoles generally have better penetration of those sites like the CNS, the eye, and the urine. There are alternative or newer agents which have been manufactured for the resistant isolates. So, for example, for pan-resistant isolates of C. auris, there are medications called ibrexafangap and fosmanogepix, which are not available in country. So, treatment duration, how long should you treat your patient? For candidemia, it's 14 days, but we start counting from the first negative culture. So you have to do repeat cultures after starting treatment. And then if there are metastatic infections, that again will prolong the duration of treatment, depending on which site the infection is in. Then all patients with candidemia should be screened for ocular involvement. And then very, very important as well is source control, where you have to drain abscesses, remove indwelling devices. And lastly, just to mention is that there is no empiric therapy. So clinicians must really make sure you investigate patients who present with features of sepsis adequately by taking culture before you start on any antimicrobials. So in conclusion, Candida auris is a major public health threat and cases are continuing to increase globally. Colonization precedes infection, so we should reduce things that would increase colonization. So judiciously use antibiotics and antifungals, and this will help to prevent development of resistance. You must be able to recognize sepsis and remember the risk factors for candidemia so that you order appropriate tests before you administer antibiotics to the patients. That is my presentation. Thank you. Let me stop sharing my screen and I will now invite Dr. Kasim to continue with the lab considerations. Welcome, Dr. Kasim.
Good afternoon.
I can hear you, but the volume is low.
Hello, can you hear me? Is it better?
Yeah, now it's better.
Okay, let me just go to slideshow. So we'll discuss some laboratory considerations in the identification and antifungal susceptibility of C. auris. A lot of this has been covered by Dr. Phoebe. It's important to note that the non-albicans Candida are now becoming more common, and the issue with them is that they have reduced susceptibility to some of the antifungals that are used that are easily available in our setup. She's also mentioned that now Candida auris together with Candida albicans are considered critical priority pathogens by the WHO, and it's of concern to all of us. This has also been mentioned. Due to time, I'll just rush through. So Candida auris is a budding yeast that almost never forms short pseudohyphae, and it's also germ tube test negative. So that differentiates it from some of the other candidas that are closely related to it, including Gilamondi, Lusitania, and Paracillosis. Unlike most of these Candida species, it also grows very well at high temperatures and high salt conditions. The issues with identification have been that there are very high rates of misidentification. And this has been because it's a relatively new species, and so it has not been available in the databases for most of the automated systems that are being used for identification. Yeah. And because it's also very closely related, then there's issues of misidentification with other related species. In terms of the challenges, even in terms of culture itself, the development of a high salt, high temperature enrichment culture-based media has made it possible for us to be able to reliably, isolate Candida auris, especially from the complex sample types. There's been an update on most of the databases, some of the databases, I would say, and there's been improvement on some of the media, like the Chromega, to include these new species that for a long time has been missed or misidentified. Some of the methods that are being used for Candida identification include your conventional methods, or biochemical manual methods. There are these automated methods as well, chromogenic media, molecular media, and MALDI-TOF. And some of these would basically start with culture, and suborot dextrose agar has been the most used media, and most of the time we include some antibiotics so that then we can inhibit some of the bacteria and give most of the nutrients to the fungal isolates to grow. And the Candida, most Candida would be cream or white, smooth and pasty convex colonies. And most of the sterile specimens can be inoculated directly. However, for the complex specimens and specimens that are, coming from non-sterile sites and so on, we usually require enrichment and inhibition of some of the other organisms. And the enrichment is what we are talking about: high temperature, high salt, environment, where you have the salt dulcitol broth that has been developed to improve the cultivation and incubation at 40 degrees. So most of the sites don't have 40-degree incubators, and this challenge can actually occur at that point. Microscopy, through a wet mount or a gram stain can be done, and most of these then would at least give you some idea that it's not bacterial, it's a yeast isolate. You're looking at some budding yeast. If you go ahead and do the germ tube test, it would be a germ tube negative test as opposed to, say, Candida albicans and so on. A common test called the API, Analytical Profile Index, which has been around for a much longer time than most of the automated systems. It has its challenges, but it's one of the tests that are easily available, at least to rule out some of the systems that are there. In this, you have the initial API 20C that was developed, but the challenge with this, other than using 19 assimilated tests, it was also having a much longer incubation, 48 to 72 hours. So a lot of work went in to develop a shorter strip called the API Candida 10 that was incubated for about just 18 to 24 hours. And another advantage is that we could now identify the biochemical changes through color changes. And now we are referring to the API web database for identification of most of these. And you see, these are the 20 and the 10 right here. So these can be used for the basic identification of most of the Candida. These we've now started introducing to some of the sites that are not able to get automated systems. However, we need to understand that some of the challenges still exist with this, and that challenge is still misidentification. If in any case there's still suspicion of Candida auris, it should be referred to another system, a higher system that is able to identify it. And these would be the automated systems. These are biochemical-based automated systems and include commonly used Vitek, also the BD Phoenix and Microscan systems. And the thing to note, if you have a Vitek in your setup, is that the older softwares do not accurately detect C. auris, but it has been included in the newer software, 8.01, but still the misidentification rates are still there. It could easily be misidentified as Hemoloni or Dubosimoloni, in which case you would need to probably refer it out. So if you have a software 8.01 Vitek 2, if a C. auris is identified, you would be able to rely on that identification. However, if you have Hemoloni or Dubosimoloni, then or a Candida species is not identified, you would need to send it to a facility that has a higher end method for identification. Yeah. As well, we have the same challenge with the other identification systems like the BD Phoenix. Yeah. If there's hemoloni identified or catenulata, or there's no identification of the Candida species, then you still have to suspect it could be a C. auris and refer it out. As well, the same is for the microscan. So one of the higher end systems that's now available in our few of our facilities is the MALDI-TOF. Yeah. So this is a detection system that detects the large molecules like the polymers and proteins and so on. Yeah. And it's a very rapid system for identification. Within minutes, you're able to get the identification, the bacterial identification, as opposed to the earlier systems that I showed you that require incubation overnight. So there are two systems, the Bruker Biotyper brand of MALDI-TOF and the Biomiro Vitek MS. Yeah. And in both of these, the newer softwares have actually now included C. auris in their database. The older softwares and versions still have issues to do with misidentification. However, most of the newer systems you're getting are now able to correctly identify C. auris. So most of the misidentified C. auris in Vitek, for example, need to be confirmed with the MALDI-TOF system, which if it's using the version 3.2, for example, for the Vitek MS, would be able to correctly identify C. auris. Then you have the issue of the aspect of using improved culture media, including the chromogenic media, yeah, which is a selective and it's a differential media that is able to use some enzymes that are species specific and allows yeast to be identified using color changes and colony characteristics and so on. The initial chromogenic agar that was specific for Candida was not able to differentiate Candida auris from the others, and it was actually giving a quite varied color ranges from pink to white to red to purple and so on. So it was not very easy to actually differentiate it from the other species. However, the Chrome Agar Candida Plus is able to do that. And with this, you find Candida auris is a pale cream, the first figure here, pale cream or light blue, colonies that have a distinct bluish halo, yeah. And you're able to differentiate, from the others, like the Candida albicans, which is a green, a bright green blue kind of color, and this becomes helpful in the lab settings. Molecular methods are not easily available, but some of our referral centers are now setting up molecular methods. So hopefully these will be easily available for use in clinical settings or, it's like the National Public Health Laboratory. If it finally sets up the molecular methods, then we'll be able to refer these isolates that you still suspect are Candida auris to them. For antifungal susceptibility testing, most of the systems we have in our labs, the automated systems, are not reliable, yeah? And this is because of lack of clinical breakpoints. So the systems are not able to carry out some, interpretation of the MICs that they're able to get. And this is also because there's lack of guidelines by the two major international systems, the CLSI and UCAST, that really guide microbiology work around the country. Currently, what we do is we run antifungal susceptibility testing via e-test, and we rely on the CDC recommendations on some of these breakpoints, and that is what we are using to report. For antifungal susceptibility, we don't use the normal systems we use for bacterial antibacterial susceptibility testing. Here we have special media like the RPMI that are then suited to carry out antifungal susceptibility testing. And this is an example of just two of these. This is caspofungin, yeah, and this is the Candida auris that has been grown on a lawn. And this strip here is what we call the e-test, yeah. And with that elliptical zone here, we can find out what the specific MIC is. Like in this case, it's about 0.125, which is sensitive in the case of caspofungin. And fluconazole on the right side here is, completely resistant. There's no zone of inhibition. Yeah, and with this, you're able to report that this is actually resistant with an MIC greater than 256. So I'll want to stop there. Thank you so much.
Thank you, Dr. Kasim, for that presentation. I'll now welcome Sylvester to give his presentation.
So thank you so much, Dr. for the presentation. I hope that you can hear me.
Yes, I can hear you.
Okay, thank you. So on infection prevention control, we are going to talk about the issues of the management of the Auris outbreak related to IPC, because one case of Auris is regarded as an outbreak. So some of the things that we are going to check about was supposed to check about the early identification and IPC surveillance. Then also we are looking at patient placement and isolation. We also check about the standard and contact precautions. Then we look at environmental cleaning and disinfection. We'll also check on the equipment and device management. Then we'll also check on the healthcare workers' practices and see how the practices was done, and also the ongoing surveillance and monitoring. Then AMS, MR, stewardship, how IPC is connected to that. Then communication and coordination. Then we'll also see about the outbreak control, then the key challenges that we faced during that time. So we have talked about the outbreak, the series overview, and we are just going to talk about now the colonization. So when we have a colonization infection, basically the colonization is just when the patient skin is colonized, and that is basically a way on how the Candida auris can get into the bloodstream when we are doing invasive procedures, maybe catheterization or a CVC insertion, or maybe during a surgical procedure. So who do we test for this colonization? The patients, for the patients we test for colonization, is basically we do the patients who are who have been using antibiotic for a long period of time. That is when we are doing the colonization. But currently what we are doing is we are doing the colonization screening when we have a case. So basically when we are doing contact tracing is when we do colonization. So basically you can do colonization today and you find that the patient is negative, does not have the CORs on the skin, but it is always advisable to repeat it after 14 days. Basically, that means that if the level of CORs in the skin was very minimal for detection, within 14 days, it will be easier to detect the colonization rate. So what do we use? We use these swabs here that you can see there. That is what we use. We use single swab to do the swabbing for the axilla and the groin areas. Then it's transported to the lab. So how do we prevent CORs from occurring? So basically contact isolation and cohorting of all suspected or confirmed patients are required, or any transferred patients pending for septic screening results. So basically realize that in some facilities, you have a room whereby you isolate your patients, or you cohort your patients who have been transferred from other hospitals, who have been hospitalized for a very long period of time in those hospitals and have used a lot of antibiotics. So basically, they normally do the septic screening. So you do the isolation to prevent maybe further spread. So also we do maintaining a septic technique during insertion of the invasive catheters or invasive procedures. Then also you do screening of all patients in admission to critical care units with signs and symptoms of sepsis. Then also you do contact precautions, whereby you ensure that we have a strict hand hygiene measures that have been put in place, that is 5 moments of hand hygiene, and we use appropriate PPEs. So also we consider thorough cleaning of equipments and surfaces, the floors and the beds, using a checklist. So basically you must have a checklist to check whether you have cleaned or not. Then also shared equipments, disinfection is always advisable. Environmental disinfection is required with 0.5 chlorine-based solution at least 3 times a day or on need basis. Then terminal cleaning is also done after discharge. So basically we have 2 different types of cleaning. We have routine cleaning and we have terminal cleaning. So routine cleaning is the cleaning that is done on a daily basis, but terminal cleaning is done at the end of the patient's outcome. Then use the right cleaning procedure. That is basically if you're using chlorine-based, you use triple steps. So how is Candida transmitted? So basically Candida transmitted through contact. So it can be either direct contact or indirect contact. So direct contact is basically when microorganisms are transmitted from a direct physical contact with a infected or colonized individual. So you can see from the pictures there, you can see the hands, two people shaking hands, and the microorganisms are just playing there. Then also you can check on the hands there. We have different types of hands there. You can see a hand which has a red color, has a lot of microorganisms around it. If you look at this other one which has long nails, you realize that the inside is not able to be cleaned very well. And if you look at this, the other one that has bluish, you realize that when the healthcare workers was cleaning his or her hands, there were so many areas that were missed during the cleaning. So in direct contact, you can see this about how this is transmitted. Basically, you can see it's through the object. So basically, there's a colonized patient or infected patient in a bed. Then the organism is left inside the bed, on the bed. Then now the healthcare worker touches the bed and touches the patient. So basically, you see that now there's a transmission taking place. And if you look at this other picture, which has red circled points, those are points that basically shows you high touched areas in your unit. So every time you always have to touch these areas when you get into those places, go into the unit. So when you do early detection and IPC surveillance, what do we do? So we do active screening. So the active screening, basically we do that. For example, the patient that we are now discussing is that this patient was one of our patients, being that we screened this patient for features of sepsis, and we enrolled this patient for one of the patients that we are suspecting to must have something. So basically screening for high-risk patients in ICU for features of sepsis and recommending blood cultures. So we look at the patient's files, we discuss the patient with the clinicians and the nurses in the unit, and we see, does this patient really require blood culture, or does this patient really require the treatment regime that is being given with consultation with the IDU team and also other clinicians. Also, at that point, also when you're doing contact tracing, you do swabbing of the axilla and groin. This is basically you're going to when you are checking on the colonization. Dr. Kasim has really talked about the accurate identification from the lab. Then also we do something called line listing. So basically we are maintaining the real-time list of colonized infected patients with help of contact tracing and management. So basically we have to maintain the list of the patients. If we had ever had a patient before with Candida auris, we maintain that line list and we look at the connection, if there is any connection between the previous case and the current case. Then also we are doing a flagging system, so where we are looking at if there was a patient who had Candida auris and was discharged, if this patient comes back, are we able to identify this patient on an entry level so that now we do the isolation or barrier nursing as quick as possible. So we look at patient placement, so whereby the patient is supposed to be placed in a single room, preferably. If there is no single room, basically you're supposed to cohort this patient, and the cohorting of these patients are all confirmed cases only. Then dedicated equipment, so you're supposed to dedicate equipment to this patient or the Auris because of the transmission. It's easily to transmit the organisms from one place to another, and also it stays in the equipment for several months, and even it can even end to a year or so. Then also a clear signage that shows that you need to be on contact precautions when getting into that room, and also to any person getting in. Also, you need to do traffic control to the isolation rooms with strict IPC measures. So basically, traffic control helps us now not to transmit these organisms from the patient to other places or to other staff or to other patients around. So there is no specific guideline on the colonization of the Auris, but basically what we advise the patient to be on chlorhexidine gluconate 2 to 4% body wash for a maximum of 5 days. So it does not decolonize, but it just reduces the burden of the Auris colonization on the skin. But use it carefully, because it clears the normal flora of the skin, and hence poses a risk for HAIs and MDROs, and even recolonization of the patient. If the Auris has gone and is still in the other surfaces, it can still recolonize that patient if you continue using chlorhexidine body wash gluconate 2 to 4%. And this is basically tells you that if you're using chlorhexidine gluconate 2 to 4% in your facility or in your ward, basically you're posing a high risk to your patients having MDROs. So always use isopropyl 70%, isopropyl alcohol 70%, e.g. surgical spirit or chlorhexidine 2% in alcohol, or povidone iodine for skin preparation. Not methylated spirit. Methylated spirit, it is not advisable to be used on a patient's skin, on a human skin. Actually, it poses risk to the patient. It's only supposed to be used on surfaces or equipments. So if you have methylated spirit, you can use it on surfaces or equipments, but surgical spirit is the one that is advisable to be used on the patient's skin for skin preparation because it has isopropyl alcohol. So we also check on standard and contact precautions, whereby we have critical issues when we are dealing with hand hygiene. So alcohol-based hand rub or soap and water is the advisable way of doing hand hygiene. And we have to maintain the 5 moments of hand hygiene. And we have 2 things that we check on. We check on compliance and also we check on adherence. So compliance basically help us to establish the baseline of the safety. So for example, an example of a compliance is that we have guidelines, we have the policies that have been placed. So when you're doing compliance, you're just complying to those guidelines. You're not doing it that it is helpful. So you are just doing it just to achieve the goal at the end of the day that you have achieved. You have adhered to the guidelines. But adherence is what really helps to stop the transmission. So you are doing it knowing that it is one of the benefit methods of stopping infection or stopping the transmission. So also we use PPEs. So the PPEs that we use here is gloves and gowns before entering the room. And when you're getting out of the room, don't get out of the room with those PPEs. They should remain inside the room. You also do strict donning and doffing to avoid contamination. So you can contaminate yourself basically when you're doing the doffing and the donning. So basically you need to follow the steps. So also you need to consider is to minimize the patient movement within the facility in case of radiological procedures, or all scans and imaging should be done at once to avoid the patient from moving from one place to another or moving in and out of the room more frequently. Environmental cleaning and disinfection also is very, very important. Here is one of the critical areas and the pillars for controlling Auris. And one of the things that you consider is use effective disinfectants only. So what has been indicated by the CDC that is very, very effective on Auris is chlorine-based solutions with greater than 1,000 parts per million for general surfaces and 0.1% for equipment. So basically, the reason why you're using 0.1% for equipment is basically it can cause corrosion on the equipment or can lead to dysfunction of all the equipment if you use it at 0.5%. Another thing that you can use, basically this one, if you use this chlorine-based, basically you must rinse with water. If you don't rinse it with water, it will cause corrosion. Also, you can use hydrogen peroxide-based solutions, which is best for equipment. So this one you don't need to wipe with clean water. Basically, you just use hydrogen peroxide-based solutions once, and you're finished that. The frequency of cleaning you have to do at least a daily cleaning. Recommended is 3 times a day, but at least you do a cleaning on a daily basis. Then you do terminal cleaning after discharge. The focus areas should be high-touched areas, including the bed rest, the monitors, the IV pumps, the monitors, nursing station, the telephones, the switches within the room, and also the chair. If there's a chair within the room, you also need to confirm to check that. During this cleaning, basically, we don't recommend you do fumigation. You need to do high dusting, not fumigation. So fumigation, basically, if you're using chlorine-based solution, which contact time is between 5 to 10 minutes, if you do fumigation, I don't think if the chlorine solution will stay on air for 5 minutes waiting for the contact time. So basically you do high dusting and not fumigation. Also, you need to focus on shared equipments. All the equipments that are there, you need to share. Also, what you need to do is avoid disinfectants that are ineffective on Candida, on the yeast or the Candida auris. So basically, some quaternary ammonium compounds are not effective on C. auris. So basically, so far, only chlorine-based solution and hydrogen peroxide have been confirmed to be effective on C. auris. The cleaning and disinfection process, we are using chlorine-based. Basically, you start with clean water. We start with clean. You clean first with soap and water, then you disinfect with chlorine solution, then you rinse with clean water. So basically, we have seen other places whereby people rinse first, then soap and water, then jig, then rinse. Basically, you're causing harm to yourself because you're exposing the organisms to yourself. So basically, what is recommended is you just soak in soap and water, then you disinfect with the chlorine-based solution, then you rinse. It will be good to go. Then for the equipment and devices, as we have talked about it, a dedicated or single patient use is recommended if possible. Cleaning and disinfection between every use is mandatory. So basically, don't say that I just cleaned it some few minutes ago and I have to wait for another, maybe tomorrow to clean it. So you have to clean it after every use. We have just talked about chlorine-based solution, and also we have talked about hydrogen peroxide-based solutions, which you're not supposed to use. Also, you need to do something called source control. So basically remove unnecessary catheters and the lines as soon as possible. Also use the smallest lumens possible device. This basically limits the growth of biofilms. Follow strict aseptic technique during insertion, the care, and also removal of the CVCs or the invasives. Also review daily and remove devices that are not required promptly. So healthcare workers practices, basically intensive IPC training and retraining plus sensitizations are required. And this one look at the hand hygiene adherence and compliance. You also check on the PPE adherence. Then you do audits and feedback systems. That is basically direct observation of staff practices. Then limit staff movement from between wards if outbreak is ongoing. So basically, we try to limit the people accessing inside the room and from other units. Also, what you need to do is also you need to continue with surveillance and monitoring. So whereby you repeat the point prevalence survey if affected units. So basically, points prevalence survey basically means that you do the testing for all those patients who are there at that particular point so that you see whatever is happening. Then environmental sampling is always required if outbreak persists. So this basically, if the outbreak persists and you are not sure where this organism is, basically you can recommend environmental sampling. This one is only done on outbreak basis, not routinely. You need also to monitor new colonization cases, infection rates, and also you need to look at the IPC compliance and adherence indicators. So antifungal and antimicrobial stewardship, IPC link. Also, you need to check on the avoid unnecessary antifungals to not treat colonization, such as skin, urine, and pus. So basically, this is where now IPC comes in. So you need to advise promptly how the colonizations are supposed to be managed. Skin colonizations, urine colonizations. If a patient is having catheters, please we remove those catheters first because maybe it's a colonization, the patient may not have infection. So the pus also you do dressing. So you also use appropriate therapies, starting with the correct first line treatment, the way Doc talked about it. Then also the dosage should also be looked at. Also antibiotics also you need to check on. Then communication and coordination. So basically immediately a notification has been done. So from the lab, the IPC team leads in the response and the surveillance and the updates. Bringing in the public health, basically early notification for collaboration of housekeeping. So this is where we talk about not all heroes wear scrubs. That's a say that I always like using because the housekeeping staff, they don't wear scrubs. But when it comes to breaking the chain of infection, they are very critical in that point, basically because during the cleaning, instruments and everything, so you need to take care of these individuals who are doing the housekeeping work. So the affected units also, you need to inform the staff and to enforce precautions. The administration needs to be aware so that they can provide resources as much and the support as much as possible. Then communication in timely, clear coordination, and the outcome. Then basically you look at if you have done all these things, we'll check as did you really control the outbreak and declare it an end, or how is it still a problem? So you basically continue with the IPC measures, encourage adherence over compliance. So why are we encouraging adherence over compliance? Because adherence this is what is really needed. Compliance is you are complying to the guidelines that have been put in place or the policies. You are running away from being penalized, but adherence is what you need to do. Then perform final environmental decontamination, terminal cleaning, and assess it using GlowJam technology, which we are going to show you. Then you also do IPC audits and review. Then you document lessons learned and update the protocols and guidelines when needed. So when we received our case of on 6th, that is a preliminary results that we were waiting for the AST. So we received a case on 6th of October. What we did, we went to the unit, we ensured that we did the communication and everything that was there. And IPC protocols, we shared with them what they're supposed to do. We also monitored, we started hand hygiene, we started environmental hygiene, and we did screening, contact screening. So contact screening, that our patient was in bed 2. So when we did contact screening, the unit has 5-bed capacity. When we did contact tracing, we screened all the patients within the unit. And apparently when the feedback came on 22nd of October, bed 1 was colonized. Bed 5, bed 4, and bed 3 were not colonized during that time. So basically from one case, for the initial case from blood from infection of the blood, now to the colonization of another case. So basically this patient was in bed 2. When we were doing contact tracing, the next patient, who was bed 1, was also colonized. So we were trying to look at where did this case come from. So we looked at, there was another case that we had in the same unit in 2025. So we checked on this, and on 27th of July 2024, in the same unit, we admitted a 13-year-old female patient from Kajiado County Referral Hospital and was placed in bed 3. You can see how beds are arranged: bed 1, bed 2, bed 3, bed 4, bed 5. So the other patient was admitted to bed 3. The blood sample was taken for culture sensitivity for both bacteria and fungi on 4th of November 2024. The results came on 10th of November of 2024 with a Candida Auris positive case. The contact tracing was done, and all the other patients that were in the unit were screened, and none of them was positive of colonization of Auris. The blood cultures of other patients also were taken because they were screened for sepsis, and there was no positive Candida Auris. This patient stayed with us for 1 year, 2 months. That was the patient was transferred back to Kajiado County Referral Hospital on 5th of September 2025 and placed in the ICU, which have a 5-bed capacity. The same ICU is where this other patient now came from, because this patient, we transferred this patient back on 5th of September. This other patient came on 24th of September. They had shared the same ICU with our first case, who was transferred back to the unit. So we received this unit from the same facility and was admitted in the same unit as the previous patient. Some of the tools that were helping us to do this environmental and hygiene was GlowJam kit. So the GlowJam kit, basically you can see the first picture is the kit itself, and the second picture shows the surfaces, and the third picture shows the hands. So we apply this GlowJam on surfaces and hands on surfaces without someone seeing, and actually we come and assess post-cleaning. If you see any shiny particles, basically there is nothing that have in IPC and in cleaning, there is nothing called partially cleaned. It's either cleaned or not cleaned. Mm-hmm. So when we checked on it, we saw the shiny lights particles. That means that it was not cleaned. Then the hands also, you look at the hands of us. These are staff hands, which also shows you that there was something on hand hygiene that was not happening very well. So this glow jam, basically, it's just a simulation of it's not a real jam, but it's a simulation of the jam. It shows you, it can help you see the missed areas when you're doing cleaning, the missed areas when you're doing hand hygiene, and also it can show you how organisms are transmitted from one point to another, both using hands and also equipment. We did hand hygiene environmental, we assessed the environmental cleaning. The results as follows. We did every bed and also the general. So the beds, basically, you can see the hand hygiene. We did a common, but now you see that bed 1 was really cleaned at 64.7%. Bed 2 was at 66.7%. Bed 3 was at 61.1%. Bed 4 was at 58%, and bed 5 at 55.6%. This is one person doing the cleaning. So basically, you can see now effectiveness of cleaning, how it is. We received after 14 days. Remember, I said contact screening. You can repeat swabbing. You're supposed to repeat swabbing after 14 days and see. So we did a contact screening swabbing, a second swabbing on 22nd of October. So during this period, we swabbed the same patients who were in that unit. Apparently, initially we had one patient in blood, then we did a screening, then second patient came. Then now here comes all four patients in the unit were Candida Auris colonization, with only one who was not having. Something that was very fun is because now the red ones shows you the patients who have Candida Auris colonization. The orange ones shows you these patients who have stayed in that unit for a longer period of time, but the green one shows you this patient was just a few days when we are doing the first contact screening. So 4 patients now have Candida auris colonization, with only one patient who did not have Auris colonization.
That was Sylvester.
Yes.
Sorry, maybe you could try and wind up so that there's time for some discussion as well. Thank you.
Okay, thank you. So we also did hand hygiene. The same results were there, the way they are. Then this just tells you, this is just the same thing that we have talked about there. Then this is the outcome of our patient, the patient 1 who was colonized. Basically, we was transferred to IDU. Deceased, who was in bed 2, but the second patient was in bed 1, basically was discharged home. The third patient who was also colonized on bed 4, deceased. The patient who was in bed 5, who was colonized, was discharged home. And our last patient who was not colonized, deceased. So we were looking at we came back and looked at the infection from August to February. How was the unit? Basically, we realized that in August 2025, we only had one organism, which was Enterococcus faecalis. Then in September, we had 4 organisms. We had Klebsiella pneumonia, we had Staphylococcus aureus, which was sensitive to methicillin. We also have Aeromonas hydrophilia in the same unit. And so we had Acinetobacter baumannii. Then in October is when we had Candida auris. From November, we had Klebsiella pneumonia, which was 1 case. December, we had Klebsiella and Candida parapsilosis. Then January, we only had 1 organism, which was gram-negative rod. Then February, we had Klebsiella pneumonia and gram-negative rod. So basically, you can see that the infection rate has really gone down after the tight measures that we did during the Auris. So basically, we came back and checked on the challenges recommendation that we had using an IPCAF tool. This is a global recommended tool for assessing IPC, whereby we looked at the IPC program. We realized that there was a staff shortage during that time and also till now, because the equipment nurse who is supposed to be dedicated to do the equipment cleaning also does other roles. So we recommended lobbying for additional staff, basically to help on IPC. The IPC guidelines, we had poor hand hygiene by visiting clinicians. So what we resolved to, instead of just doing audits, we resolved to on-site hand hygiene reminders and reinforcement. So basically, we are working on how do we adhere rather than compliance. IPC education and training, we checked on a very big gap on compliance and adherence. Basically, now we're targeting refresher training and also sensitization and mentorships. Looking at the HI surveillance, we checked on the shared equipments and the materials for infection. So basically, if you don't dedicate equipments for each patient, or if you don't dedicate some instrument for each patient, we'll be still transmitting infections and the HIs. We looked at how multimodal multimedia strategies are there. The limited implementation because of the few reminders and resource constraints. So basically, we looked at enhanced multimodal approach, reminders, supervision, and behavior change. So one of the things that we checked once was about behavior change. This is about culture. So we have been used to doing this. How do we change it? Then monitoring and audit feedback in consistent of hand hygiene and cleaning compliance and adherence. So you realize that today it's done good, tomorrow it's down. So basically we need just to do routine audits and real-time feedback. We also checked on workload staffing, and this is where we came to find a problem because we only had in 5 patients, we have 3 nurses, and these 3 nurses have to work on all those 5 patients. So basically, we recommended increased staffing for safe patient care. Then built environment and supplies, shortage of PPEs, disinfectants, cleaning towels, only 1 housekeeping staff. So we really asked for increase of supplies, dedicated cleaning materials, deploy more housekeeping staff, organize terminal cleaning, so that now when we have a terminal cleaning, public health can bring other staffs to help in terminal cleaning. Our general remarks, basically, we realized we had a lot of systemic gaps during the outbreak because there was no good coordination, being that now we had a shortage of staff. We also have a very minimal number of housekeeping staff, resources, and other things. Then we recommend strengthening of IPC systems and prioritize resource enforcement and accountability. And that comes to the end. So we were tasked also to come up with protocols and procedures when we were starting the project. And some of the guidelines that really helped us was about the SOPs that we developed on Auris screening, the management of colonized patients, or infectious disease outbreak management in healthcare facility, HAI surveillance, environmental cleaning, and MDR1 series isolation precautions, and the CDC and WHO protocols. So thank you so much.
Yeah. Thank you, Sylvester, for that presentation. It was a bit lengthy, but IPC was really critical in getting these outbreaks under control. So I think we'll just proceed straight to the Q&A. The first question is on the role of procalcitonin as an inflammatory marker to track fungal infection. So please clarify. I'll direct that to Dr. Lois Achieng.
Okay, thank you. So procalcitonin is an inflammatory marker that we often pick in the presence of bacterial infections. There are a few things that can give you a false positive for calcitonin. So you must consider the clinical situation, not just treat the test. So some antibiotics may give you a false positive for calcitonin. Sometimes it may be erroneously high, particularly in patients with significant kidney disease. So again, it's a clinical, you treat the patient in front of you, not the test. Generally, in fungal infections, the procal shouldn't be elevated. So if you have a high CRP, low procalcitonin in a patient who's in the ICU and is septic, then you really need to screen that patient for other non-bacterial infections, such as the Candida infections.
Yeah, thank you, Dr. Lois. The next question is from Elizabeth Okello, who is asking to kindly explain multifocal colonization. I think this is with regards to Candida infection. So I think I'll take that one because I had mentioned multifocal colonization. And this just means you're isolating Candida from various sites. So for example, from the urine, from the respiratory tract secretions, from other cultures, other samples that you've taken other than blood. So that's a risk factor because when the patient is colonized at multiple sites by Candida, then that's a risk factor for invasive candidiasis. The next question is, someone is asking, does it mean that no matter how severely ill the patient is, one cannot give treatment until the lab results are back? Maybe I'll direct that to Dr. Lois again.
Okay, that's always a difficult situation to deal with, particularly where you have a critically ill patient in the ICU. So where you think there is a severe bacterial infection, where your patient is septic or your patient is in shock, then you take the samples and you can then empirically start antibiotics depending on the focus of infection. So even when starting antibiotics, you didn't just do a blanket, let me start antibiotics, but you have to think about what is the likely focus of infection? Is there source control? Can I remove unnecessary invasive devices? And some of the invasive devices that are commonly used and that are common sources of infection are things like urinary catheters. You may have peripheral lines with phlebitis, lines that have been there for a long time and are soiled, or central venous catheters. So you really have to think about what else can you do for the patient. When it comes to empiric antibiotic use, again, the focus helps you in determining what the most appropriate antibiotic to start empirically is. And here I'll direct you to the national guidelines on antibiotic use, which looks at all the national data and sort of gives us an idea of what we can start empirically, even after as we wait for culture results. Importantly, must take cultures before you start antibiotics. When it comes to antifungals, and I know Dr. Phoebe had presented some scoring criteria that have been used, there isn't very good evidence for reduction in mortality with empiric antifungal use as opposed to waiting for the Candida cultures. So that's sort of a gray area. There's certain situations where you'd consider initiating. So for example, in the context of severe neutropenia, in a patient with neutropenic fever who is not responding to antibiotics, then you can initiate the antifungals. I hope that helps. Thanks.
Yes, thank you for that response. So the next question is directed to Dr. Kasim. So most labs report infection as fungal elements or yeast cells seen. So how do you distinguish C. auris from the common Candida albicans?
Usually, what is reported as just fungal elements seen is a specific test. Yeah. And most of the time, that's just how you ask for it. It will not be a culture test. If you've done culture, they'll tell you whether there's growth of an organism and which type of organism has grown. You would do the germ tube test to differentiate Candida albicans from Candida auris. And when you find a Candida that is germ tube test negative, you should take it. If you have no methods to do the identification, you should refer it to a place or facility that can be able to do the identification and AST. Thank you.
Thank you. The next question, someone is asking, does the renaming of the organism have any microbiological or clinical impact? That's to Dr. Kasim.
No, I don't think it has any clinical impact other than clinicians probably not knowing that the names may have changed. We are very slow to adapt to these names. So it will take us time to actually start changing the reports and so on until we are probably all on the same page.
Okay. So the next question is about immunodeficiency. So someone is asking, is immunodeficiency a consideration in the prevalence and severity of the disease caused by Candida auris? So I'll just answer that one, yes, because we had said it's one of the risk factors for getting invasive candidiasis and will increase your risk of receiving antimicrobials because you'll have multiple infections and therefore you'll be at risk of getting C. auris, which has increased mortality. So the
Dr. Lois, has Phoebe disappeared?
Yeah, I think so. I can't.
Sorry. I think I muted
Maybe
myself.
Okay, take that question.
Okay, so where was I? With the poor lab equipment. I think I was on that question. So this is for Dr. Kasim. So with the poor lab equipment we have in the country, especially in level 4 facilities, can we confidently commit that we can isolate and treat this fungus in most of our patients? Or should the suspected patients always be referred to higher levels? Has there been any effort made maybe to develop labs in other places?
Thank you. So maybe, I don't know, level 4. We are struggling with trying to build the capacity of some of the larger level 5 facilities and even the level 6 facilities when it comes to Candida diagnosis. And that's what basically this project has been trying to do, trying to elevate the capacity to be able to do this as well. The bacterial work, bacteriology work, in these facilities, in some of these facilities was low, but has now come up, and we've been trying now to match the capacity to identify candidates. I am not very sure about level 4 facilities and their capacity to make this diagnosis. Dr. Lois, have you visited some of the level 4 facilities in the country?
Yes, and I think you rightly mentioned that many of the facilities may not have capacity. But having said that, I think an important component of our work is learning to do sample networking, because we may not have a multitude of equipment or Vitek in every single facility, but you'll find counties. So let's say you go to Kisumu County, JOTRH has Vitek equipment, which means the facilities around can work on networking their samples to JOTRH. If you go to Machakos County, Machakos level 5 has Vitek, so it can actually serve the facility. So I think it's about making the best use of the resources that we have, even while we don't have unlimited resources, and learning to do sample networking, and also making use of the National Public Health Lab. And many of the counties have a sample referral mechanism to the National Public Health Lab that can support some of the work that you need. Thanks.
Yeah, thank you. So the next question is still to Dr. Kasim. Salim says, many thanks for the informative presentations, but he believes the challenging part would be the identification of C. auris. So in resource-limited settings like our sub-county hospitals, the use of the API 10 that you mentioned would come in handy. So what's the specificity and the sensitivity when it comes to C. auris for that API 10?
Thank you so much. So I think I mentioned API because that's probably the first. And when we're looking at Candida, we look at all Candidas, yeah, because we said even for the critical identification of species of Candida that cause candidemia is important, yeah. So that's where the importance of API comes in. Is it a Candida albicans? Is it so? If it is then having difficulties in terms of giving you a species, then you suspect that it could be a different type, yeah. So it has its utility. However, the sensitivity for C. auris is very low, yeah. In that case, so you would start suspecting if it gives you species that are not very clear, or it's unable to give a species, then you refer to another facility, or to the National Public Health Laboratory that has a MALDI-TOF as well as a Vitek to do the identification for you. So it's very good for the initial workup that you're working with, yeah. If you identify, you grow a Candida, it's germ tube test positive, or you use the API, it tells you it's Candida albicans, that's in keeping, you can go ahead and report. If it's a non-albicans, the species is not very clear, then you can actually refer that for further identification. Thank you.
Okay, the second part is for Sylvester. We have also noted increasing resistance of C. auris with current disinfectants. Which disinfectants would we recommend for effective IPC and duration of disinfection? I think, Sylvester, you had presented, but you can repeat just for emphasis.
So thank you. So currently the disinfectant that is recommended is chlorine-based solution and hydrogen peroxide for equipments, chlorine-based solution for services. And basically you need to do the cleaning at least thrice on a daily basis. Thank you. Or actually after every use also.
The next question is about empiric treatment, but has already been answered. Is C. auris a concern for healthcare workers in critical care only, or should those of us in the OPD be equally concerned? I'll direct this to Dr. Lois.
Thanks. So most severe Candida or invasive Candida infections occur in critical care units just because these are the patients that are at highest risk. Unfortunately, many of our outpatient departments almost act like critical care units because we receive critically ill patients. Many times they're kept in the casualty or OPD waiting for a bed in a critical care unit. And if we do not observe general hygiene, as has been discussed, then we risk spreading because patients who come from other hospitals may also land in the OPD. So may risk spreading infection and colonizing our outpatient units. And you can't tell who has C. auris or who's colonizing C. auris as they come. And the only thing we can do is ensure that we all achieve a higher standard of hygiene. So hand hygiene should be at 100%. Environmental cleaning should be as good as possible. Where patients have come from other hospitals who've been in other hospitals for a long time, you really do not want to be mixing them with other patients because they are at higher risk for having not just Candida, but also other drug-resistant pathogens. So it's around weighing what comes into your outpatient department, but most importantly, maintaining high standards of hand hygiene and environmental cleaning in all your units.
Yeah, thank you. So there's a question here from Valentine Orina. In a report of an outbreak, what is the epidemiological chain of reporting? I take it to mean like if I discover there's a cluster of Candida auris cases in a facility, should this be reported maybe to a higher level or we just manage it? Maybe Sylvester can.
So basically, before even we get the results for the CORs, it's always communicated from the lab, and also our PI always have the information about it. So basically, she's in a position to respond to this perfectly. As we start on the IPC measures, I believe other reporting systems are always in place. So maybe she can respond to that.
Okay, all right. So in terms of reporting, and this is not just for Candida auris, this is for any other dangerous pathogen. So one, within the facility, good timely communication, as had been highlighted before, is important. So where it is identified, it means the other healthcare workers, clinicians, nurses need to be aware so that, they're also observing the contact precautions that are put in place. It's important to inform the head of the unit, and the head of the unit would also inform either the medical director or the med sup, depending on the chain within the different facilities, so that information is cascaded to other healthcare workers. Remember, we said a patient who's in ICU and has C. auris. It's not just the ICU staff who come into contact with this patient. It's radiology who are coming to do ultrasounds or portable x-rays. It's the kitchen staff who are coming to serve food. It's a physiotherapist, occupational therapist. It's the lab people who are drawing samples. So that the whole hospital really comes into contact with the facility, with the unit. So it's important that senior management in the hospital is aware. In terms of how we report this, all this data is then provided to the National Public Health Lab, because the National Public Health Lab is charged with collating information on outbreaks that may occur in different facilities. Many times the outbreak is limited to one facility, and we usually work with the facility leadership, the facility clinical teams, to ensure containment of an outbreak as it occurs. Thanks.
Yeah, thank you, Dr. Lois. I think there are two more questions, which I think we've already sort of answered during the presentation. But in view of time, I want us to end the presentation. So maybe it's an opportunity for final comments. I don't know if Dr. Kasim, Sylvester, whether you have anything before Dr. Lois gives us the final word.
So, well, my comment from the IPC prevention control aspect is just that we have to adhere to hand hygiene, environmental cleaning, and also strict IPC measures when it comes to any infection across in the UA units and across the hospital. Thank you.
Dr. Kasim, any final comments?
Thank you. So I think mine is to say that we probably need to advocate for improvement in our diagnosis for Candida in all our facilities, and network samples, consult across, and then we should be able to take care of what's going on. Some of the areas and county facilities that for a long time were saying they did not have Candida and so on. Through this project, we've seen that the burden of Candida is there. It's just that it was not being picked. So I think let's consult across and develop some networks which can help our patients. Thank you.
Thank you, Dr. Kasim. And maybe final words from Dr. Lois.
And thanks, Dr. Phoebe. I don't think I have a final word because the team has presented this so well. So mine is to thank the team for the excellent presentation. And thank you, Phoebe, for the excellent moderation as well as the presentation. I think the main things that we need to go out with, IPC is important. Clean hands prevent infections. 2, antimicrobial stewardship. Do not overuse antibiotics because you lead to emergence of other infections that are difficult to treat. Thank you.
Okay, thank you. And I think thank you to all the attendees, and enjoy your day.